We'll begin the discussion about trial designs with a little bit of the goals, the aspects of good design, some considerations, what are the basic phases of clinical trials, and our goal of simplicity in design. The essential questions that you should be able to answer at the conclusion of this presentation are: what are the basic trial goals? What are the basic statistical goals? What are the overall design goals and considerations? And what are the elements of good clinical trial design? Let's start first with the two basic areas of clinical trial goals. They are to estimate and to determine. Estimate and determine what? So estimate means to approximate calculation of the value, number, or quantity. That is the definition from the dictionary. And in terms of clinical trials, that is exactly what we want to do. We want an approximate calculation of the value of our outcomes in each of our treatment groups. So in the simplest case, that's treatment group A and treatment group B. One may be active, one may be a placebo. They may be the same intervention with different doses. They could be two different surgical techniques. But we're really looking to estimate those outcomes. We want to know the magnitude of the intervention effects. So how big was the effect? And in clinical trials, this means change. So we have our baseline or pre-intervention measure of the outcome, followed by our endpoint outcome at whatever time is determined to be end of study, be it 1 week, 1 year, 10 years. So first you would estimate in treatment group A, how large of a change was there? And in treatment group B, how large was a change there? Then we're looking to estimate the differences. So estimate the difference in the intervention effects. How large of a difference was observed in those changes between the interventions? So generally, you wouldn't simply compare treatment A and treatment B at the end of the study. You would actually first calculate how much of a change was observed in group A, how much of a change was observed in group B, and then compare those changes. Did A change or improve more than B improved? And that's really key to actually know the difference between the change in the intervention and the difference in the changes. So let's say treatment group A, it's your standard treatment or it's your placebo. It did not change at all. There was no statistical change in the placebo. Now let's say treatment group B had a statistically significant change. So B improved. Those are the first questions we're going to look at. Then we're going to look at, did B improve more than A? So that's a fairly straightforward example. Consider the situation where the placebo group has a small negative change. That means the placebo group didn't get any better. It's not statistically significantly different from zero, but it did go in the worsening direction. And then consider that treatment group B, the new intervention, had a small improvement. Again, not statistically significantly different from zero, meaning that there was no real observed improvement statistically in group B. But when you compare A to B, B is better than A. You need to know before you present those results that while the small improvement in B is statistically significant than the small worsening in A, there was no actual statistical change in B. And so be prepared for critics of your research to come at you from every angle. And that is the first step. If you declare a treatment difference, is it because one got worse and the new treatment didn't get better at all? Then that new treatment isn't really helpful, is it? And that takes us to our next goal. So first we need to estimate the magnitude of change in each of the arms and then the differences between those arms. And this leads us to the second goal, which is to determine. Again, from the dictionary, determine is to ascertain or establish exactly as a result of research or calculation. So this is very literally what a clinical trial is aiming to do. We want to look at the safety and efficacy of the treatments. It's important to note the distinction between efficacy and effectiveness. Efficacy is what we're doing in clinical trials. It is the performance of an intervention under ideal and controlled circumstances. Effectiveness is the performance under real world or observational or clinical conditions. So remember, a clinical trial is not clinical treatment. So how somebody is treated in a clinical trial is a very strict set of controlled circumstances. How someone is treated in a clinic is considered real world conditions. So if we go back to safety, it is to determine if the interventions are safe and if there is a difference in the safety profiles. So again, going back to the concept when we estimate, it's not just estimating the change in each intervention, it's also estimating the difference in those changes. That's the same with safety. We're looking at side effects, adverse events, and serious adverse events. You wouldn't want to say that there was no difference in the safety profile of a placebo and an intervention if everyone died. So just because there's no difference in the proportion of deaths doesn't mean they're actually safe. So again, it goes back to looking not only at the differences, but also the individual treatment arm safety profile. Efficacy, of course, is the main goal of the clinical trial, is to determine if the interventions are efficacious and if there is a difference in that efficacy. It will assess if the interventions work. Are they effective? Are they measuring what you want them to measure? So let's say our goal with an intervention is to improve walking speed over 25 feet. Did that actually happen? So treatment group B may beat treatment group A, but if the walking times in B are still statistically equivalent, or not equivalent, but if the walking times in group B are not statistically significantly improved, then it would not be efficacious. There are certainly times where, say in this example, the 25-foot walk is not improved, but the distance that people can walk unaided is improved. And that's where you get into secondary analyses, some off-label use, and potentially using this information from this trial to field another trial. So we want to estimate and we want to determine. We want to estimate magnitude and we want to estimate differences. We want to determine the safety and we want to determine the efficacy. Those are the simple goals of our clinical trial. What are our statistical goals and our design goals? Well, our statistical goals, we sort of covered a little bit with estimating the intervention magnitude with precision. So our trial goal is to estimate the intervention magnitude. Our statistical goal is to do that with precision. And we want to minimize the bias. Now, recall that there are multiple types of bias that can enter into a trial in a statistical manner. We want to make sure that our endpoint of interest, and actually all of the endpoints we'll be assessing, are reproducible and measurable with minimum bias. So it's very difficult if you're using a subjective measure. For any measures that are subjective, you want to provide training such that any two assessors or evaluators would rate a participant with the same characteristics in the same manner. So you wouldn't want participant 1 to be given a score of 4 by evaluator A and a score of 14 by evaluator B. That means you have bias somewhere. So that's what we're looking for is to estimate the magnitude of difference with precision. We want to estimate the intervention variability. So if we have participants that enter that are seemingly homogeneous and they end up in different places, what is that variability? So that's determined person level variability. And if you have subjective measures, you want to be aware of the rater variability or the variability inherent in the outcome itself. So if you take a measure like the EDSS in multiple sclerosis, The known variability, because it is somewhat subjective, is 1 point. This endpoint goes from 0 to 10 in half-point steps, with the exception of 0 to 1 in a full-point step. You can take the same person living with MS and give them to 2 different EDSS evaluators, and over time, those scores would have a variability of 1. You need to be aware of the intervention variability on your endpoint. Why? Very simply because I would not want to design a study to detect a difference in the EDSS of less than 1 point if I know that the variance on the EDSS is 1 point. So knowing a little bit about your endpoint and how the intervention acts upon that endpoint is key to meeting your statistical goals. And then, of course, we also want to compare the intervention groups with minimal bias and with an understanding of the variability. For the design goals, these have been classified very well by Piantadosi in 2005. You can see the course syllabus for the listing of that textbook. Piantadosi states that the design goals are to quantify and reduce errors due to chance, so to minimize bias, reduce or eliminate bias, yield clinically relevant estimates of effects and precision. So the change that you observe has to have a clinical relevance, or it has to be biologically meaningful for the patients upon which you intend to use this intervention. So if it only reduces someone's blood pressure by 3 points, systolic, so you reduce it from 145 to 142, it is unlikely that will have a clinical effect. If you have a large enough sample size, that may be statistically significant, but it's unlikely it's clinically relevant. We want to be simple in design and analysis. We want to provide a high degree of credibility, reproducibility, and external validity. That means if someone else were to run this study the same way that we did, they would get similar results. And we want to help influence future clinical practice. Why are you running this trial if you don't hope to produce a clinical relevance or change the way that clinical practice occurs? So think about these two things side by side. You cannot achieve the statistical goals without achieving your overall design goals, and vice versa.